Hmm.
How many pushes did you say on burn?
Hmm?
How many pushes did you say on burn?
Like
Two?
2 or 3.
Oh, okay.
She wasn't fully sure.
She's not sure.
Watch it'll be the
I
two
only,
things
I
I
only
don't
she wrote
study.
the stuff. Say again?
I said, watch it'll be the two things I don't study.
Yeah, there's really, I'm gonna be honest, for as broad a topic as burns are, they are not terribly complicated. Big thing is shock management, because of how much fluid you lose through the wounds. So, again, just for the video's sake, I'm gonna go over this a third time now. For our test purposes, we need to understand nursing care of all different types of burns, or, well, these moderate and major types. Within that, we need to understand how they affect respiratory, cardio, vascular system, how we address comfort issues, thermoregulation, as well as GI and GU issues. There are many different types of burns. They all affect things differently, and depending on the source of the burn, you will kind of change your expectations. So the difference between someone coming in from a house fire, where they may also have significantly more respiratory symptoms due to smoke inhalation, you're going to be seemingly more concerned about maintaining their airway, versus someone involved in like a chemical spill, where you know, they may have more soft tissue damage, more yeah, I mean, you can deal with, on top of the burns now, that's a very permeable membrane, and other things can get in. It gets bad. Oh, and electrical. Electrical burns can also cause dysrhythmias. We'll talk about that. So again, this slide really just kind of, it's a overview of what is a burn. It really just happens when the body or a tissue absorbs more energy than it can dissipate, resulting in cell death. That's really all it is. Pathophysiologically, can be a result of systemic, or it can cause systemic injuries due to cell stuff just winding up in the circulation, causing symptoms similar to rhabdo, but again, not on this. The big one is the fluid shifting so all the capillaries have become damaged, right? So now you just have kind of open ends to all the vascular, your veins and arteries, and they're semi-open, so they're kind of clotted, but they don't really go anywhere. So the end pressure there, kind of all that fluid, you're going to see a lot of that clear serous fluid just kind of accumulating around the burns, and they can eventually look very wet. But the problem with that is now if they're leaking fluid constantly, especially if it's a large percentage of their body, you run the risk of dropping their blood pressure and then suddenly not perfusing their organs, leading to shock. More pathophys. Your skin has a lot to do with thermoregulation. If you destroy the skin, you can't thermoregulate. It's pretty simple. Hypovolemia, we already went over that. The eschar will generate that thick, leathery scar tissue, usually converts to fibroid tissue after it heals. It doesn't heal super well, but even while it's healing, it doesn't stretch well, leads to everything feeling really tight. It's very uncomfortable for the patient. Super big one, this guaranteed will be on the test. Hypovolemic shock is like numero uno risk for any burn patient. And we're talking significant burns here. Like, I'm not considering hypovolemic shock for, you know, a sunburn. You're not leaking that much fluid. You haven't really damaged the underlying vascularity of the tissue. However, coagulopathies can exacerbate these issues. Again, if the body's unable to plug up the damaged ends of those capillaries, it's going to be a mess. So other complications, infections. Again, your skin. We learned about this in AMP. We learned about it in Nursing 110. Your skin is your first line of defense from infections. So you destroy that, and you are instantaneously more susceptible to systemic infections or local infections initially. Airways can swell. You know, that's a big one. When soft tissue gets burned, and I have pictures later on of soft tissue burns, and you'll see immediately how badly they swell. Circumferential burns of the chest can restrict, because remember I said, so if you burn the chest, even, and the notes say circumferential, but even just a significant portion of the chest, that skin becomes so tight, and it really restricts the ability for the chest wall to open and close, leading to significant respiratory difficulty. So there are surgical interventions they can do, usually like a fasciotomy, but again, that will not be on our test. So,
What the heck is this? Go away.
oh, I forgot on the last page. Compartment syndrome. So again, if you have a circumferential burn around the majority of one of your limbs, when that tightens up and swells, it will basically act like a tourniquet, cutting off blood flow to that limb. Very limb threatening. Usually a fasciotomy is the best way to save that. So, this is going to sound kind of obvious. The skin closest to the source of the burn is going to be the most damaged. So usually the outer layers will initially, the outer layers and the layers, or the area closest to the area of the initial source of the burn is going to be the most affected. This can, and again, I'm slight rabbit hole here with electrical burns. That can be a little different just because of the way electricity travels. Yeah, I can't see most of this. This is mostly EMS stuff. So, burn depth. This will likely be on our test. So, classified into superficial, partial thickness, and full thickness. So we can alternatively define those as first, second, third degree. When they can't be accurately estimated, that's usually due to the mechanism of the burn, either like a chemical or radiation burn may just not appear as expected. Again, radiation is kind of like electricity, it propagates weirdly, so the damage may be where the particles ionized might be deeper into the skin. We learned about that in cancer. So, really this is a generalization used for our sake as nurses to estimate the amount of care, to kind of triage this patient into how much care they're going to require throughout their stay. I have some examples here. So clearly, first, degree, you only have the outer epidermis. Second degree, you have bubbling noted, and then third degree, you've got significant damage to lower depths of skin. They appear very different. They go from relatively normal appearing, just red, to more wet to dry. As this heals, it will also become very wet, as fluid and capillaries are rebuilt, and, you know, depending on how full thickness, as veins and arteries are rebuilt, to reperfuse the area, it will start to become more wet. And these are the ones down here where we're really concerned about, shock due to fluid loss. So depth of the burn, extent of the burn, if critical areas, you know, face, genitals, anus are, they say hands, feet, yeah, they're just harder to fix, it's hard to regain dexterity in those appendages. But the face, airway, genitals are going to directly impact the survivability of the immediate injury. Pre-existing medical conditions, and then age. Greg did mention understanding differentiations in risk for both pediatric and elderly would likely be highlighted. Quick question, did everyone download the excerpt from ATI that Professor put on the, that? She circled stuff.
Right, that's what I'm looking at now.
Exactly. So that first slide.
I got an extra copy if you need it.
And actually, I will be posting, I have about 2/3 of it done.
Okay.
But I am transcribing that entire document into a Google Doc that is searchable and typed, so you can actually highlight and make changes.
Oh, nice. Even better.
So, they'll probably have that done by the end of the day.
Thank you.
AI is amazing, you know.
I know.
I'm like, yo, transcribe this, and then I just like fix the formatting.
Good, I love it. Like a little personal assistant.
So, your pediatric concerns, their skin is just ratioed a little differently. Elderly, same thing. And elderly just don't heal as quick, so. There's a couple ways to measure your burns. In the ambulance, we generally go with rule of 9s. It's pretty easy to estimate. The other one I've seen is the rule of palms. Each palm is about, depending on how big your hands are and how big the patient is, like 1 to 3% of their body. So you just kind of go 1, 2, 3. It's got 3 palms, about 9% of their bodies burned, you know, give or take. So the slides here say 1%. Again, if I have huge hands and I'm measuring someone significantly smaller than me, that's why I said 1 to 3. But this TBSA acronym is Total Body Surface Area. You're going to see that a lot in these slides. That's an EMS thing. I don't think they use that acronym in our book, but it's the surface area of your body. Just a picture. So this is the rule of 9s here. So everything here is divisible by 9 roughly, either in some, 1.5 times to half 9 or double. So you can see how the percentages of head and face. So this is only the front, mind you. So 18% is just the face. The back of the head is another 18%. 12 and 12, 9 and 9. Again, this guides the triage of these It does not necessarily change, what you're going to do to the actual wound. It just changes their risk of shock, infection, etc. This is all the EMS stuff. We don't need to do scene size up or Illinois. Don't need to do that. She said a lot of this is going to be next semester, where we're doing like emergency triage. We just do decap BTLS, yeah. Right, was there? Okay, actually, so this last portion here, this one's big. Soot around mouth and nose and singed nasal hairs. Big indicator that there will likely be airway swelling. Like as soon as you see any singeing around the nares, that means they breathed in something hot enough to burn their hairs. Incredibly indicative of they've had some upper respiratory burn, could possibly be middle or lower respiratory burn as well. Usually see that with, well, 4th of July is a big one that I see. Kids playing with bonfires, rednecks playing with bonfires, house fires. That was a lot when, I don't know if anyone remembers, it was the nursing home that burned down in Westchester. The Friends. Which one?
Berkeley or Friends?
Barclay. When Barclay burned down, someone having a cigarette, actually, caught the oxygen in the walls on fire. Oops. Yeah, a lot of people died. That was not super. A lot of the people that we did get out had significant burns to the respiratory tract. Breath sounds, that's a big one. You're going to hear that pretty rapidly. It's going to sound like a dry, whistly wheeze. Cysternura. Can they move their fingers? If the muscles in their hands have been damaged, they're not going to be able to move their hands. If it's deep enough that it burned the nerves, they're not going to be able to feel their fingers. Contained vital signs, continue to monitor. These patients change quickly. They'll be okay, while they're compensating, and then they drop off the cliff. And then you turn them over and see all this like serous fluid underneath them as they've just been leaking, oozing. More of the same. This is kind of more EMS stuff. Okay. Traumatic injuries. So, the big one we need to know is, and this was circled in the notes, if for whatever reason the agent that caused the burn is still present, say it's a chemical, right? I had just had a patient the other day. He had drain cleaner, lye, splashed in his arms. Horrific. It was horrific. He could not get it all out and he was driven by a private vehicle, not an ambulance. Showed up in the ER and I should put up a picture of a Morgan lens. If you've never seen one, they'll give you the heebie-jeebies. It's a contact lens, the entire size of your sclera, with a, what's the quick connector we use? The The lure lock, it has a lure lock on it, you just hook it up to saline bags, and you just run saline through their eyes. If you don't like eye stuff, dude, that'd be the heebie-jeebies. It's a Morgan lens. Yeah. So, they're soft, it's not like it's a hard contact, they're like very soft silicone. But you are taking a solid object and inserting it into a burned eyeball. They're not gonna like it. It's incredibly unpleasant. But the idea is that we can then run a full liter of fluid directly behind the eyelids. You know, I'm not worried about them blinking, I'm not worried about them. This is more, so again, if you're seeing hypoperfusion, low blood pressure, you're seeing, is that Bextran? Treat for shock. Holy shit. Keep them warm. Don't let them get cold. If they get cold, they're not gonna warm up ever again. They'll be dead. Aggressive with the fluids, you keep their pressures up. As we discussed earlier, albumin is great. If albumin is not available, LR is great. Anytime you don't want fluid to third space, LR, it's wonderful. It's what it was designed for. The rest of this transport stuff. You don't need to know that. Specific burns, we don't really need to know that. Inhalation burns, that's pretty obvious. The big one with inhalation is like inhalation of powders that can continue to burn because you can't really irrigate them out. There's not a good, until the body just kind of clears them, you're just kind of SOL. Carbon monoxide is a big side effect of, you know, being stuck in a vehicle or a car, or I'm sorry, a vehicle or a building that's been on fire. Fires produce a lot of CO, and we all know what happens to the body when you inhale CO. What does CO do to your blood? Kind of, yeah. But what's
Or diminishes your oxygen carrying capacity.
Why?
It knocks oxygen off or something through iron.
yeah. What, it binds better. It has a stronger affinity for the heme than the solo O2 does. That carbon molecule is more energetic and wants to bond stronger than O2 does to the heme. It essentially, and Gabe said it, drops your oxygen carrying capacity. Now, the real buckler here is that the way our pulse oximeters work is by measuring the conformation change. We're going all the way back to biochemistry. Remember your conformation of a protein? So as oxygen binds to the heme, it changes the conformation of that protein as that laser light shines through your finger. That laser light is trying to pick up how much of the protein, that heme protein, is conformed in the filled state. Does that make sense? Well, it's filled, it's just not filled with oxygen. So, you need to learn to treat your patient, not your monitor. If you know this person's been in a burning house and they're short of breath, don't look at your monitor and go, well, they're sitting at 100%, so fuck them. You know, put them on high flow. You need to get, if there's any residual CO left, you need to get that out. The blood that already has that CO in there, it's done. You need to wait either a transfusion or chelate it out, whatever. I don't think that's important for our sake. Yeah, we don't need to worry about hydrogen cyanide, unless you're working in a war zone. Okay, chemical burns. So, you can see exactly how much this swells. Getting a Morgan lens behind that swollen eye is going to be excruciating, unpleasant. The wound management there is going to be very unpleasant. I'll see you. I'll put this on the, Discord tonight.
Okay, thank you.
Of course. Yeah. Wear your safety goggles when you're cleaning your house. Yeah, we don't need to know about pH and all that, concentration. So, I don't know, I can't imagine she's gonna ask us, how would you stop the burning? You remove the offending agent. That's, if there was going to be something like that on the test. Yeah, we don't need to know, treatment methods. Okay, so that's the ambulance way, because we don't take Morgan lenses on the truck. So we just literally we'll just pry their eyeball open and just hold a IV tubing. That's an electrical burn. We don't need to know that. That's more electrical. Radiation burns. Meh. Yeah. So, duplicate. Changes. And I'm going to open up the textbook thing that she sent. Because there were some good practice questions at the end. Let's first things first. So this is a good non-graphic way to look at burn staging. So you can see the layers. This is broken up a little more detailed than we need to know. I am sure for our test, it's just going to be superficial, partial thickness, full thickness. That deep full thickness is when you've actually charred the bone, everything's turned, like you actually have flesh that has turned to ash. That's not a recoverable condition. So, it is under, here under the circled nursing care stuff. Stop the burning process. I don't know if any of us are planning on providing care at the burn scene, but yeah, do that. Oh, remove jewelry, man. If someone comes in with a burn to their hand, even if it's just a sunburn, jewelry off immediately. If you need to lube it up, get it off. If you need to cut it off, get it off. What will happen is as that swells, it can tourniquet the finger and half a chance that it was if you don't get the jewelry off. This is also why I really don't like titanium rings, meteorite rings, all those exotic metal rings, because we can't cut them. We need to get the fire department out, and they use a tool to pinch it off, and it shatters it. Cool water. Do not use ice. We did not talk about cold burns. So like dry ice burns, nitrogen burns, things, people using exotic refrigerants and stuff, that can happen too. Puff, puff. So, as far as respiratory, it's your basics as a respiratory test. The big things you're looking for is, can they expand their chest cavity? Has the burn affected their ability to expand their chest? Or will it, if, as things tighten up and heal? Internal burns to the upper airway. Does this person need to be intubated? One of the big things we do pre-hospital, if someone has burns in their nose, we've got these little, we call them nasal trumpets or NPAs, and they get two of them, we squirt a whole bunch of lube and then yoink them right in their nose. The nose can swell all at once, but it'll swell up against the rubber tubing. They're very uncomfortable. I put one in myself. They make you want to sneeze. Sometimes they have to be taped in place. So chest physiotherapy, similar to, if they have lung burns, they're going to accumulate a lot of fluid down. It's going to interfere with gas exchange. So they're going to be doing a lot of coughing, a lot of the thumping, a lot of the, what else? Inhaled medications to try and keep those airways from swelling shut. Cardio, central and peripheral pulses. So again, the reason you do both is those circumferential burns to a limb can, as they heal, swell and then occlude blood flow to that limb. So if you notice one of their arms has diminished pulses and they have a burn to their upper arm, maybe something's occluding the blood flow. That needs to be addressed immediately. Fluid replacement, this is the big one. We can almost guarantee we will have a question on this. Large bore IV access. You're going to keep an eye on their labs, but more important is keeping them hemodynamically stable. You don't want to fluid overload them, but we do not want them to go into shock. Who knows what shock is? I think that's next semester. Everyone know what shock is? When I say the word shock, I know you do. Yeah.
Me?
Yeah, what's shock?
It's just that there's not enough fluid inside the body.
Kinda, yeah. But not enough fluid to do what, shock? To perfuse, right. Yeah, literally every type of shock means you don't have enough fluid in you to fill the space available and perfuse your organs. That's all shock is. Super simple. Shock is not, there is the end result of cardiogenic shock versus hypovolemic shock versus anaphylactic shock versus neurogenic shock. They all do the same thing. Yeah, right. They either swell all of your vasculature in like anaphylactic shock, they swell the vasculature. So think about a coffee cup. If I swell my coffee cup, now it looks like it's mostly empty. Functionally, you know, there's not enough coffee in there to fill the cup. So I'm not gonna feel great about getting a mostly empty big coffee cup. That's all. Or if all the coffee leaks out. I'm gonna be mad about that too. That's hypovolemic shock. Burns generally result in hypovolemic shock because the serous fluid, or albumin, is leaking out of the vasculature. When that happens, we don't have enough water to fill the veins, or the artery, the vasculature, to perfuse the liver, to perfuse the brain, to perfuse anything. And we're not even thinking about muscles at this point, or the healing process, it's core vital functions. What you're gonna see, let me pull up. Is it right? That's right? Yeah. That's a coagulop. I want. Hypothermia, acidosis, and coagulopathy. This one. I thought there was. Anyway. So because things aren't circulating, you're going to see increase in acidosis because it's not circulating to the lungs to blow off the CO2, right? You're going to have acidosis. Coagulation, when blood stagnates, when it just, again, because there's not enough really for the heart to efficiently move it around, it's going to sit still. The moment blood sits still, it likes to coagulate. And then hypothermia. Like I said, when the body gets cold, the heart slows down, worsening the shock. Because as soon as the heart slows down, now you have low volume, and the thing that's moving what little volume you have is now moving even slower. You're now in a spiral that is very hard to recover. Up, up, up. That's cirrhosis, that's that thing. That's this. Okay. Comfort. So, my big takeaway was monitor your pain treatments. Healing is the horrific part of this. You are keeping them very high. Your patient is and it's, yeah, the healing process is going to be pretty horrific here. It's not going to be comfortable. Your opioid analgesics and your anesthetics are going to be key to treating. So we're thinking fentanyl, pretty much. And then my favorite is ketamine. I think ketamine's great. Fewer side effects, and we'll leave it there. So as soon as we start administering opioids or opioids, we're watching respiratory. In the event of an airway burn, I need to look this up, but I don't know in hospital management. I know pre-hospital we generally intubate to maintain that airway. Because again, if they have laryngeal burns, we need to make sure that doesn't swell shut. If they have bronchial burns, then we need to make sure that doesn't swell shut. So we're just gonna yam a tube down there and keep it open. I need to do some research to see if that is maintained in the hospital now. Someone wants to look that up. It might be in this textbook. That's cute. The non-pharmacological guided imagery, music therapy, and therapeutic touch.
Touch them.
Don't touch their burns. I hope I don't need to say that. Yeah, okay, yeah. Provide a restful environment, non-painful touch to help increase, yeah, massage of non-burned areas. So, do involve the client in their care. Unless they're, besides themselves on. The big one, and I've mentioned it a couple times, is thermoregulation. It initially sounds like a comfort thing, but like I said, deeply related to shock management. Don't let these people get cold. It's very hard to get them warm again. So, so this one, this last thing here is, oh my gosh, it's a touchscreen. I didn't know that. Wow. Alright. So, a low-grade fever. I don't think, I could see it being a test question. Like, patient presents with a low grade, like a 99.7 fever, 99.9 fever. As like a way to misguide us thinking they have an infection when the fever's normal, following a burn. Well, I guess we'll see. But a low-grade fever is normal because of the healing process going on. Again, as long as they have the fluid in their body to maintain circulation. So, if their GI system, mouth, tongue, etc. got burned, they may need an NG tube. They might be getting tube feed while their mouth heals. I don't think the book goes over mouth care, oral care for someone with oral burns. So I'm going to say we don't need to know it. But, so the big one I would say here, monitor stool, vomit, and gastric secretions for blood. And then assess for hypomotility. So if their peristaltic sounds start to decrease. That could also be a combination of the analgesics. So if we're giving them narcotics, it can also slow peristalsis, but you don't want it to stop. They might need something to excite. Urinary systems. So not just related to burns to the genitals, right? So there is going to be a profound amount of trash getting cycled out of the body as the body apoptoses and clears out all dead tissue. It needs to get rid of it. As we've been learning, a lot of that gets converted to, what does Billy Rubin get converted to? Before poop and after heme, because heme is what we're converting into blank. Billy Rubin gets converted to urea. Ammonia, the ammonia gets converted to the ammonia gets converted to urea, and then we clear the urea. I'm sorry. I think I offset. The bilirubin gets cleared in the feces, and then the nitrogen gets fixed as ammonia, and then ammonia gets fixed as urea. And we clear that through the kidneys. And, but all the other trash cycling around may leak, just because of the profound amount of trash, cellular trash getting cycled out, may wind up in the kidneys. So if we start to see blood-tinged urine, if we start to see blood in the, like actual blood in the feces, that should be moving things like, hey, maybe we need to up their fluids, they might be having kidney damage due to the amount of ammonia, the amount of protein that they're moving out of their body. Now, if they do have burns to their genitals and they are unable, and I read this somewhere in the book, that they may require a catheter. Just keep the hole open. So, horrific, but it's already burned and damaged, and it's not gonna stretch, but yikes. That is confounded by the fact that they are already at a higher risk for infection. But I would say the higher risk there is their urethra fully closing, and then just having like a bladder injury because they can't avoid it all. That's so this would be the alternative, I might say, is like, we would not necessarily catheterize someone who did not have genital burns, right? Because of the increased risk of infection. All those white blood cells are off doing other stuff, and if we introduce another, like a caudy sort of risk, can overwhelm the body. So, reading this list of restrictions, what kind of room restrictions would we call this? Do you hear that?
Hmm?
What'd you say?
Neutropenic.
Yeah. So, basically a neutropenic restriction to the room. I don't think they explicitly call it that, but it's pretty much it. Tetanus, they're gonna get their tetanus shot. That's, I could see that being, on the test. Strict asepsis. So that's like surgical aseptic technique, not just clean. So sterile gloves, gown, etc. And nutritional support, they're gonna get, so they're gonna be double their calories and double their protein. I don't think that's gonna be on our test. Don't think we need any other meds. She said meds are next semester, right?
Yeah, there's none.
None, yeah, good. Alright, let's go do Increase Jones. A nurse in a provider's office is assessing the client who has a severe sunburn. Which of the following classifications should the nurse use to document this burn? A, superficial. B, superficial partial. C, deep partial. Or D, full thickness. I would probably say. Because sunburn is 9 times out of 10 superficial. Superficial partial would have to be a wild sunburn. You've ever seen that episode of Seinfeld with butter? Where Kramer decided he goes and sits on the roof covered in butter, trying to suntan, and he wanted to fry himself. It's very funny. Since we were making Seinfeld jokes earlier. nurse is caring for a client who has sustained burns over 35% of total body surface area. The client's voice has become hoarse, a brassy cough has developed, and the client is drooling. The nurse should identify these findings as indications that the client has which of the following: pulmonary edema, bacterial pneumonia, inhalation injury, or CO poisoning. C? Great. I would say the same. A nurse is assessing a client who sustained deep partial thickness and full thickness burns over 40% of the body 24 hours ago. Which of the following findings are common during this phase? Select all that apply. Hypoglycemia, decreased blood urea nitrogen, hyper K, hyponatremia, or decreased hematocrit. See? What else?
Are we assuming that they're getting treatment?
Sure. It doesn't say, so let's,
It's on the lab test. Decreased sodium, increased potassium, elevated bond, elevated glucose.
C, D,
Decreased hematocrit.
so why is it not big? Oops.
Why is it not B?
Why is it not big? Without looking at this, I want you to think, we just talked about it. Why?
Well, on here it says elevated due to fluid loss.
What's another reason why it would be high? What just happened to the body?
Injury.
What just happened to the
Down
body?
in red blood cells.
Huh? Well, more than just red blood cells. What else is getting broken down?
Cells.
Yeah, all the dead tissue. So it's got all that nitrogen-containing protein. Urea is how we transport nitrogen out of the body. So if we're breaking down all these cells, that's going to be up. Not just, I mean, yes, volumetrically it's going to be elevated because of the low fluid volume. But also, it's going to be high because we're cycling out so much of that nitrogen-containing trash that's burned cells out of the body. I could make an argument, depending on their nutritional status, for hypoglycemia, just because the amount of energy that they are using to heal and keep the body alive and under the amount of stress.
We should give you more with these questions.
Are there answers?
No.
There are no answers. Okay. Even in the book, there's no answers? Or you had to buy that?
There is.
Yeah. But don't shout them out until we're done all of them. Until we're done all the questions. All right, a nurse is caring for a burn client whose calculated 24-hour intravenous fluid requirements are determined to be 5 liters, 5,000 milliliters. What is the total volume in milliliters that the nurse should infuse after the first 8 hours of fluid resus has infused?
Should get the first half in the first 8 hours.
Huh?
I'm pretty sure it was in the PTI.
I can believe that.
Yeah, that's right.
Yeah. Okay. Half the fluid in the first 8 hours. And the remaining don't know if I'm gonna remember that.
Was that the Parkman formula? Like the first half. In the first 8 hours, and then they'll make it over the next 16 hours.
No blue marker? Our IV fluid's gonna be green. So, not saying that you're gonna be infusing using a 5-liter saline bag, but just total volume. Total volume is being infused. Okay, cool. A nurse is preparing to administer fentanyl to a client who sustained deep, partial thickness, and full thickness burns over 60% of the body 24 hours ago. The nurse should plan to use which of the following routes to administer this medication? Subcutaneous, oral, intravenous, or transdermal? Let's start with which one you're absolutely not going to do. Transdermal. That's probably bad. Skin's already gone. What do we think the answer is? Yeah, they're in pain now. A nurse is planning care for an adult client who has sustained severe burn injuries. Which of the following interventions should the nurse include in the plan of care? Select all that apply. Limit visitors in the client's room, perform a 24-hour calorie count once a week, increase dietary protein intake, instruct the client to consume 2,000 calories a day, restrict fresh flowers in the client's room. You should probably also restrict flesh flowers, but that's all the time, because those are gross. What do we think? Sure? Yeah, why not D? They ain't a lot, unless they're teeny tiny. Like it's not a fixed amount. Why not B? See that?
No,
It's
it
too
said,
long.
it said nutritional support, perform a calorie count daily.
Daily, correct. Not once a week.
Oh, it said once a week. So
Yeah.
every 4 days.
Yeah, the question, that is a confounding answer. You know, you are going to be doing your calorie counts daily. We did say increase their protein, and then they're on neutropenic restrictions, basically. Okay. Identify if the following skin coverings are used as temporary or permanent grafts. Ooh, I did not study this. Let's define each one. What is an allograft? They gave
It's from the same species.
Got it. So that's from a human.
Autograft is your own.
Correct.
Allograft is from another human.
So what is cultured epithelium? Lab-grown skin. Yum, yum. That's getting pretty incredible. All the like 3D printed skin graft stuff. There was just an article that came out. They're getting better at 3D printing mesh frameworks, and they just started using mosquito proboscis as print head nozzles.
That's fine.
Because they're basically the exact, they're very inexpensive, because all you gotta do is, I know, it's a fucking pop, you know? I'm here for it.
This took me back to 2010.
Okay, so, which one's permanent and which one's tempo?
I would think C would be permanent.
Maybe. I know an autograph would be permanent. Alright? It's your own skin, it's gonna heal up. I would assume an allograft would also be permanent.
You know, it's like a EPTT.
I have no idea about C. Xenograft is almost always temporary. Your cells, I do not believe will grow into the fish cell, and then I don't know if it's divided off.
I don't know for skin. I know for organs like permanent.
Yeah, because you're not gonna reopen it back up.
I don't know for skin though. I can't imagine it's permanent for skin.
D and A. I'm looking at the ATI book.
DNA or temp?
Or temporary.
Oh.
C and
B. Interesting. Good to know. I was wrong.
I can see why A is not permanent.
Yeah, I mean,
Maybe you'd be on immunosuppressants.
yeah. Yeah, but we can transport, oh, but you're already burned. You're not gonna be on immunosuppressants on top of being burned. Okay, yeah, that's fair.
the critical thinking.
And there's a critical thinking question at the end.
Is it?
Learning scenario. All right. A nurse is reviewing the care of a client who has an autograft skin covering over a burn injury with a nurse who will assume care of the client at the end of the day. What should the nurse include in the review? Use the ATI active learning template therapeutic procedure to complete this item. What is application of a allograft? What's a skin graft? What are we doing? Right? Pretty much. You cover the burn so that the foreign skin can do at least part of the job that the patient's old skin used to do, which is, thermoregulation and keeping fluid in the body.
Because it's an autograft, I would also want to look at where they took their skin from.
Oh, it's an autograft, not a, sorry.
They're fine.
I read it as allograft.
My autograft is somewhere with the dust before.
I wonder if it was the patient I had.
Chester County, it's like 4 years ago.
Oh, no. No.
This was a while ago.
This is being recorded.
This was like, oh.
This is going on Discord, so we'll talk about it later.
That's why I keep
This is
going.
before the new building even opens.
Oh, no. Yeah, I had a guy with necrotizing fasciitis of the scrotum.
Oh, yes, so that was why.
It had tunneled into his abdomen. It was pretty horrific.
Yeah, you bet.
It bone involvement and everything was gnarly.
Bone and bone.
Anyway, so description of the procedure, I'm fairly certain it's basically just covering the wound with the skin, keeping it what? Way up, puts the lotion on the skin where it gets the hose again.
This work, man.
Yeah, it's all right. what was his name, Wild Bill? Yeah. Alright, what are some nursing interventions? Charlie, give me a nursing intervention for an autograph.
Like informed consent.
Cool. Yeah. Okay.
Neurovascular assessment.
Cool. Shot. Hell yeah.
Monitor for infection.
Uh-huh. Charlie? Did I?
Mm-hmm.
Oh,
Rejection?
theoretically, I mean, it's your own skin.
Yeah, so it's like it's not happening.
Give me a different one. I'll come back to you, Liz.
Payments.
Cool.
That was really quick.
On page
You could do like a psychosocial.
Yeah.
Pay them on,
Yeah.
how big a deal.
You could do shock prevention, because there's still a risk for shock. I mean,
Educate them on
Yeah.
that issue.
educate them on like scar formation, maybe support group, maybe not at this stage in their healing journey. But like, they're gonna be like significantly disfigured, you know. Maybe makeup tutorials. Yeah. Teach them how to put some concealer on.
Immediately after surgery.
I don't know if you want to consider.
No, you don't. Don't do that. That is dirt, in fact.
Rub some dirt.
Rub some dirt. I don't think there was anything else. How does everyone feel about burns at this point?
It's gonna be what it's gonna be.
It's gonna be what it's gonna be. Like,
I'm not really wasting time.
yeah, it's like 2 or 3 questions. Okay. I'm gonna stop the video. Was there anything else anybody wanted to go over today?
Mhm.